Accelerating Clinical Trials December webinar. My name is Ipsita Banerjee, and I'm the National Training Coordinator with the ACT Consortium. Today's talk is entitled Health Policy Trials Unit, Closing the Gap Between Evidence and Policy. Today's talk will be presented by Dr. David Campbell, Dr. Amity Quinn, and Terry Saunders-Smith from the Health Policy Trials Unit. Today's talk will be about 45 minutes, and it will be followed by a 10-minute Q&A period. We encourage you to put your questions into the Q&A box throughout the talk, and we'll try to get to as many of them as we can. Please note that today's talk will be recorded. A little bit about the Accelerating Clinical Trials ACT Consortium. ACT Consortium was funded in 2022 by CIHR, and it was established to facilitate, optimize, and accelerate the conduct, implementation, and results translation from high-quality, high-impact, randomized control trials to improve health in Canada and around the world. The ACT governance model is composed of 23 committees and working groups, and today's webinar is brought to you by ACT's Training Committee. The ACT Coordination Center is located in Hamilton, Ontario, at one of our host clinical trial units, the Population Health Research Institute, PHRI. And as such, we wish to recognize and acknowledge that we are located on the traditional territories of the Mississauga and Haudenosaunee Nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. This agreement was created to bind the nations of the Haudenosaunee Confederacy to the Great Law of Peace. The dish represents the shared land, while One Spoon reinforces the idea of sharing in peace. We hope to bring a similar spirit of collaboration to the work being done by the Canada-wide members of the ACT Consortium. And with that, I'll pass it over to Shrikant Bangdwala, one of the co-chairs of the ACT Training Committee, to introduce today's speakers.
So good afternoon, everybody. I'm really excited to hear today's seminar. This is one of the 11 clinical trial units, or CTUs, of the ACT Consortium. The Health Policy Trials Unit is a unique group that is there to support the investigators on clinical trials, especially on health policy clinical trials. So we will not take any more time from them, and let's listen to Dr. Campbell, Dr. Quinn, and Terry Saunders-Smith. Over to you guys.
Thanks, Shrikant. I think Ipsita did a land acknowledgement from where they're located. Sorry. We also had a land acknowledgement since we're located in Calgary, which is the land area with the Treaty 7 people and the Métis Nation of Alberta Districts 5 and 6 and many other urban Indigenous people. And so take a moment to reflect on the land where you are and the importance of the land for Indigenous people and really for all of us. Okay, so what is the Health Policy Trials Unit? So we are a group that was funded, as Shrikant mentioned, from the ACT Consortium. We're also a part of the Center for Health Policy, which is within the O'Brien Institute for Public Health. And that was coming to be right at the same time as ACT. And it was just, we all just grew together, and it was a really fun moment to create this unit. So we do research ourselves, but we're also available to help design studies and help run policy trials, which you'll be learning more about as we go along today. So Dave and I are like the core faculty, but we have 9 associated faculty and collaborators, and Terry's our lead coordinator, but we have some other coordinators working with us and other trainees and staff. And we're working on growing and building and being able to support other policy trials as we grow. So what is a policy trial? Even when Shrikant was just introducing us, it's like, what's a clinical trial? What's a policy trial? What's a pragmatic trial? Is there a clinical trial of a policy, or why are policy trials different? So this is something we've even been trying to figure out how to define and explain and explain what we are. What we envision and how we are defining policy trials are applying randomized methods to test social, economic, and healthcare interventions that improve health. And along with that is often understanding why they're working. So if you guys are probably familiar with more like pragmatic trials, some implementation science trials, I think that's kind of more the space that we're in. But we're not just thinking about testing like a change in delivery to one unit. We're more thinking, how would like an entire healthcare delivery system change delivery of a certain type of care, or how would a public health agency improve how vaccine uptake is implemented. So it's these more sort of large scale interventions. How is this different from a clinical trial? I mean, often there are very similar types of design and operational things to keep in mind. But if we think more about a clinical trial on this continuum of explanatory to pragmatic, if a clinical trial is more on the explanatory side, whereas a policy trial is like the most possible pragmatic direction you can possibly go. The clinical trial is more focusing on testing a drug, like does this work? And there's very rigid like inclusion criteria. And we're thinking about sort of the outcomes being more like research relevant. Whereas in the pragmatic trial or policy trial, we're thinking more about, does a treatment work like in its wild environment, right? So it's the usual care experience, and we're going to inform decision makers, not pharmaceutical drug companies. And so we're thinking about maximizing generalizability, having broad inclusion criteria, and then like, are the outcomes relevant to the decision makers that will be informed by the policy that we're testing? So another thing to think about in policy trials is like the result of the trial are not the only type of information that are going to guide decision making for a healthcare system or for a health authority, for example. So there's, in addition to the data, there's patient stories, there's how much things cost compared to other things. Another thing to think about is like the timeline that things happen on and how quickly you can get information. And I think we probably all know it's pretty hard to do a quick trial, though we're trying to figure out how we can speed that up. So these are just all things to think about, in addition to just the policy trial itself, like all of these other components of evidence that you would want to take into account, necessarily in designing your trial, but in the other kinds of sort of layered on studies and information that you would want to be including and sharing with policymakers. Okay, so why do these kinds of trials need special support, like from a policy trials unit? As you'll learn next from a couple examples from Dave, they're can be very complex, and they need to often be larger than clinical trials to find effect sizes. They're not legally required like doing a drug trial would be. So it can often be harder to get funding. It involves a lot of partner engagement. And then another thing, this eyes on the prize thing, is to just think about, like, it's not about doing a cool study and publishing it. Like, if we're working on these partnerships with decision makers and with systems and actually trying to test things that would change how those systems work, the real prize here is changing the system and forming the system so the system works more effectively. And that's really the main goal. be keep in mind. And with that, I think I'm handing it over to Dave to give a couple examples.
That's good. Thanks, Amity. Yeah, I'm happy to walk you through a couple of examples of policy trials that our group has been involved in to date. And these are just a few. Terry will tell you about some others that we have ongoing, but these are some that we've finished or nearly finished, where I think there's some learning and good illustrations of some of the challenges that come with trying to run these very large, very pragmatic trials. So the first one I'll tell you about is, we refer to it as the Food RX study, or it's a study of a healthy food prescription incentive program for patients living with type 2 diabetes and food insecurity. So our protocol was published a few years ago, and we're just in the final stages of this trial, actually, expecting to be able to report results in the first half of 2025. But to give you a sense of what the trial is all about, I will... there we go. So this study is designed to test the incremental impact of a food incentive. The primary outcome is hemoglobin A1C, or blood glucose levels. And the secondary outcomes that we're looking to observe and the impact of this incentive include things like dietary intake and food insecurity. And we have two groups. Obviously, it's a parallel group randomized trial. So it's random. Patients are randomized into one of two groups, one being the control group, or the healthy food prescription comparison group, where participants receive a food prescription, but nothing beyond that. And really the policy element of this that we're looking to test is the incremental impact of a healthy food incentive. So if you give people additional funds with which they can use to purchase healthy foods, can we change their food purchasing behavior and therefore improve their health outcomes measured by A1C as our primary outcome? And so this trial, as I said, has been going on for a number of years that I've been co-leading with Dr. Dana Olstad, and some of these slide credit on these go to her. But I just wanted to walk through some of the challenges that we've faced in the course of this study to help you, if you're thinking about doing a pragmatic policy trial, to think about some of the things that you may encounter along the way, because I think these are common, not just to our study, but to many different studies. So primarily is recruitment, and this is not a challenge that's unique to policy trials. I know many clinical trials face recruitment challenges, but in the policy trial space, this is particularly challenging because we don't recruit usually from typical recruitment centers. It's not usually hospitals or research units that have dedicated staff that are recruiting for us. And in this case, in the Food RX trial, we were trying to recruit initially from primary care clinics. And any of those of you that work in the primary care setting know that primary care is not optimally equipped to facilitate research and to help with research. They just don't have the staff and the expertise to do this. And so that was our intention when we first started, is that primary care clinics would identify participants for us, do the initial screening, and then refer participants on to our research team for further eligibility and consent. The challenges that we ran into were clearly, first and foremost, the staff time and workload. That the staff working in the primary care clinics just simply didn't have the time to dedicate to this. Their time was essentially fully booked with clinical tasks, checking in patients, doing their clinical work, that asking them to add anything to that was beyond the pale. And there's no embedded or dedicated research staff within primary care clinics like there usually is within hospital settings that are more geared towards clinical research. The second challenge we faced with recruitment is that even when there was staff who were willing to help us, they often didn't know who to approach, how to screen their large lists and databases of patients to know who might be eligible for our study. So because the inclusion criteria for our study, we needed to find people who had been experiencing food insecurity and who also had an A1C, or a blood sugar level, in a specific range. Our recruiting sites told us that they just didn't have the information that they needed. And so the result of these challenges was a low yield, that within the first many months of recruiting, we've kind of extrapolated that if we continued on in this path, we would only end up with about 100 of the participants that we needed out of the 400 from our predetermined sample size calculation. And so we clearly realized that a change of course was needed in order to fulfill our recruitment and get on with this pragmatic study. And so the solution that we came up with in order to address this challenge was to add additional recruitment pathways, so that not just primary care clinics, but this clinicians in any setting. So pharmacists and specialists or dietitians or nurses were all able to identify participants and do a much more brief initial screening and refer on to us. So we simplified the pathway, we streamlined it, and we opened it up to a much broader range of healthcare providers to help us achieve our goal. And even with that, we found we were still struggling. So we had to open up a third recruitment pathway, which was to advertise the study widely and have participants essentially self-refer for the study if they'd seen it advertised at their local food bank or on a website, or had received an email from an insurance provider, etc. So with these three modified pathways, we've been quite successful and actually able to reach our predetermined sample size calculation, which was 400, and actually even extend beyond that by adding some subgroups. We actually have been able to reach a sample size of 600 for this study, which should allow us the power to detect all that we need to in our analysis. So there's an example of how one of the main things with doing a policy trial is needing to be flexible and needing to alter things as you go. In the same vein, the sites told us that they had a hard time confirming eligibility during baseline data collection, or this is after participants were recruited and sent to our study team. We had to identify whether participants were eligible. And the eligibility criteria, as I said before, was that people had to report food insecurity and they had to have an A1C in a certain range. And with respect to food insecurity, it was quite interesting that we found that many times clinicians knew of patients personally and knew that they faced food insecurity. They'd had long conversations about that participants' challenges accessing and paying for food. But when it came to entering our baseline data collection tools that were validated in the literature and used extensively, many participants still said no, that they didn't experience any of these food insecurity things. We know there's lots of reasons for that, is, partly social desirability bias. People are more likely to be open with these types of challenges with a trusted healthcare provider than in a research survey or questionnaire. And the other challenge we ran into was that people would go through all of the testing that we had outlined, and their A1C level would come back and it would be below our cutoff. And so we would have wasted all the money on getting their labs done and getting their questionnaires done, paying them for their time, and finding out that they're not actually eligible for randomization. And so this led to obviously both of these challenges: slow recruitment, that we were excluding more than we were including, and also the high cost that we had to pay for people to go through this, even if they weren't going to end up in our study. So those were some challenges that we had when you try to do a pragmatic trial. I think a lot of times when you do a traditional clinical explanatory trial, well, you need to have all that data up front before you proceed with things. But in this case, we were trying to do things in a more pragmatic, participant-friendly manner, and that's what challenges we ran into. And so the solutions that we came up with is, one, we actually lowered our A1C eligibility threshold initially from 8 to 7 and ultimately to 6.5, which we had to trade off between the statistical power of having the right sample size and the malleability of patients coming into the study with a lower A1C, meaning there isn't as much room for improvement. So we discussed this at length and ultimately decided it was more important to have an adequately powered study and that the effect size would still be there even if we recruited a lower risk population. We also started accessing, we got permission from a health authority to access the electronic data repository for participants so we could see what their last A1C was. So our research staff was able to go and say, well, this person had an A1C done 1 month ago and it was 5.8%. So clearly they're not going to be eligible. So we're not going to bother them with all the hoops to jump through for confirming eligibility. And lastly, we expanded the number of indicators of household food insecurity. And so in addition to answering one of those 18 questions that's been validated, we also started taking people into the study who also told us that they had perceived income inadequacy. So again, expanding the realm of eligibility into the study. So this is all done within the first few months of the study, needing to revamp and change. And that's, I think, one of the biggest challenges with a policy trial, is that it often requires this kind of flexibility. We also ran into similar challenges with the intervention itself. And so when we actually initially designed the study, we had hoped that we could offer a subsidy for an array of healthy foods for people to purchase in supermarkets, and that people would receive this designated subsidy for to allow them to purchase healthy foods. And it could only be used with healthy foods. But the challenges that we ran into was that the supermarkets we were working with didn't have the technical capacity to do that. Well, they didn't have a system built in where they could operationalize this. And to do it manually would be hugely time consuming and costly for us to pay them to do that. And so we did find one large supermarket chain that was willing to implement a subsidy for a limited list of eligible foods. We were able to work with them. But there were some challenges with it, that it was because it was a new program. They hadn't done anything like this. There were initially challenges with participants not getting the subsidy in the randomized intervention group. And so this was very early in the study. We realized that the intervention wasn't working as intended, and that required us to stop the trial for a few months and work intensively with our shoppers, with our supermarket partners, to be able to revamp the program and make sure that we had all the checks and balances in place to address the issues that would come up. And then we slowly reintroduced the program with 20 participants, making sure that the program was working properly. We instituted a helpline with research staff who were actually on call to, for participants if they were at the grocery store and the subsidy wasn't working. And again, this is one of the challenges with a pragmatic study like this, is that we didn't have one supermarket location. This is a provincial study. And so even though it was one chain, we wanted participants to be able to be in our study from all over the province. And so it causes some significant hurdles when you're working with such a large partner in a very pragmatic way, where it's hoping to mimic what would be done in real life. And so that's one of the big challenges that we have encountered with our trials. And we've had ongoing challenges and the incentive itself, because it has become somewhat more convoluted in terms of the operationalization. Some patients find it hard to understand or use. And this is why we always come back to the notion of this being a pragmatic RCT, where we're testing the effectiveness, the real world delivery. So not how does this work in an idealized setting, which is often what our clinical trials do with patients who are a highly selected group of people with an intervention that they can't go wrong with. Well, when we do a policy trial, we're really interested in how would this work in the real world setting. And that's really what we're trying to get at with this study. And with that, we've accepted that some proportion, and from our data, it seems like it may be as much as 20 or 30% of the people randomized to the intervention will essentially never use it because they don't know how to use it, or it's not functional, or it's not useful for them. And this is part of what we investigate with a policy trial. I want to give you one more example from our group, and this is a study that's got a long title there, but we call it the ACCESS trial. And ACCESS was a study that we just published last year. And this was our first policy trial that our group had conducted, and it spun off obviously into conducting many more policy trials. But to run you through quickly what this study looked at is a 2x2 factorial trial where we randomized almost 5,000 Alberta residents who were over 65 years of age, low income, and a high cardiovascular risk. And as a factorial trial, they were randomized to one of 4 groups with 2 interventions. So there are those who received copayment elimination. So that means free medications. So they got rid of their 30% copayment for their high value medications. The second group received a novel self-management education and support program that we designed in conjunction with an advertising company. The third group received both of those. And the fourth group received their usual care, or didn't receive any specific intervention. Because we did this in a factorial way, we were actually able to essentially conduct 2 trials in one. And so we were able to publish 2 separate manuscripts detailing the results of each of these interventions separately. So participants were randomized into one of those 4 arms, and they were followed for a 3-year period. And this allowed us to follow people for the primary outcome, which was focused on avoidable hospitalizations, heart attacks, strokes, and death was our composite primary outcome. And the results of the first study, looking at the impact of copayment elimination, is depicted here. So this is our Kaplan-Meier curve, where you can see that for the primary outcome of people having one of those events I mentioned, there is essentially no difference between the intervention group and the control group, which was quite interesting. So the takeaway was that getting rid of people's copayments seems to result in no improvement in their hard clinical outcomes. The second trial, however, looked at the impact of that self-management education or the marketing approach, and these are our Kaplan-Meier curves for that study, where you can see that in the top left is our primary composite outcome. The curves start to diverge at about 6 months into the trial and stay separate throughout, such that those randomized to the self-management education and support group were less likely to have one of the outcomes of interest than those in the control arm. In panel D of this figure, you can see that it's primarily or exclusively driven by a change in the rate of ambulatory care sensitive hospitalizations. And when we looked at our outcomes, we actually saw a 34% reduction in the number of hospitalizations for the intervention group, which was highly statistically significant. So quite an interesting finding. So that's the ACCESS trial. And throughout this study also, as our first pragmatic policy trial, you can imagine we had lots of learnings that we went through in this study. Again, first was recruitment. And if I was to be totally honest, at the outset of this study, I was quite naive and thought it would be as easy as taking candy from a baby, that we're giving people free money, essentially. We're giving them free medications, and these are all lower income people. Clearly, everybody in the province is going to want to be part of this study. And Terry's laughing because she probably remembers these days where we're way back. Terry was our clinical trial coordinator for this study when we launched, and we thought, oh yeah, we'll be able to recruit in 6 months. That'll be no problem. We'll get 5,000 people in a jiffy. And that clearly was not the case. This is just a study timeline that shows that we launched our study in November 2015, and almost a year later, we had to kind of scratch our heads and say, well, we've got 365 people randomized, and we knew that we needed nearly 5,000 people to be adequately powered. And so we had to make some fairly significant changes, which we did. And within another 2 years, so from September 2016 to September 2018, we fully enrolled our study with the 4,700 people. So clearly something that we did in that intervening space made the difference, and we were able to achieve our sample size. So again, the idea that we need to be flexible and make changes, and these were some of the things that we did, is that we expanded our recruitment opportunities from just a very narrow focus on healthcare recruitment to relying heavily on community pharmacies, doing some mail outs from Canada Post and other patient registries, using media outreach, etc. And at the end of the day, we published these recruitment results along the way and showed that 1/3 of our participants came from pharmacies, 1/3 came from registries, and the other third came from a mishmash of other sources. But you can see that if we'd stuck with a very traditional clinical recruitment strategy, we would have only ever achieved 8% of our target sample, focused on physician or clinical recruitment. And so when we're doing big pragmatic studies, we need to think very pragmatically and broadly about the recruitment. And you can see one of the things that we did along the way was using the media. And you can see that media only accounted for 10% of our recruitment success, but it was clear with this graph that there were certain media attempts that worked better than others. As you can see in this timeline figure, that after there were press releases marked as with these dots on the bottom, either from Alberta Health Services or from the University of Calgary, there was a very significant uptake in our recruitment efforts after those. So, paying for several weeks of Facebook advertising, on the other hand, was remarkably unsuccessful for this participant group, with paying about $10,000 for Facebook advertisements. We were able to recruit 2 participants via that strategy. So some things work, some things don't, and I think that's one of the important things is this trial and error strategy when it comes to recruiting for these studies. We also, in the ACCESS trial, had some data collection issues. And, when we designed data capture systems that were pretty traditional, REDCap-based measures, which many of us probably do in our traditional clinical trials, and we figured that participants would complete these data collection forms electronically in our REDCap interface. We anticipate that some people would need paper instruments, given that this was a low-income senior group. And so we did create a pathway through which people could complete surveys via postal mail and be scanned in through iDataFax software. And this seemed like an easy automated solution. It turned out that all the data submitted through this method had to be manually checked and verified. And what we hadn't anticipated was that, so this is what the iDataFax looked like. People could fill them out on paper and it would digitize them, but they all had to be verified. And what we hadn't anticipated is that most people in the trial, so almost 5,000 people, opted to do their surveys by paper. And our office was constantly inundated with hundreds and thousands of surveys that were coming in, each one that needed to be entered and verified by research staff. And to make matters even worse, many participants weren't even comfortable or able to complete paper surveys, which meant that our team spent countless hours on the phone with participants completing dozens of pages of surveys for each participant in the study. And while our office didn't quite look as orderly or tidy as this, it probably could have. In many days, it probably looked even more like this, with research assistants' phones ringing off the hook and taking multiple calls from participants trying to get the data in. One of the other challenges that we encountered in the Access study is how to deal with attrition. And we all know that differential attrition in clinical trials can introduce bias into randomized studies and cause problems with power if one of the subgroups has significant attrition. And while at the outset we knew that those who were randomized to the control or the self-management education arm might be somewhat disappointed about not receiving the free medications intervention and therefore more likely to withdraw, what we didn't anticipate was kind of the extent of that. And so what you can see here is that, you know, we have randomized roughly the same number in each group, and roughly the same number died in each group or moved out of the province. But where we saw a huge difference in the withdrawals was for people withdrawing for non-death or migration reasons. So this is just people who decided they didn't want to keep receiving the education intervention, or after being randomized to control said, I don't want to be part of this study anymore. And so that, you know, fairly sizable number, a quarter of the people randomized to the education arm saying they didn't want to be in it anymore, this could seriously threaten the validity of our study. Fortunately, what we're able to do is use a very pragmatic way to link people's data to the Alberta Kidney Disease Network or to our administrative health data sources in Alberta. And our health data sources are very similar to those that are held by ICES in Ontario. So we have population registry data about whether people are alive or when they die. We have data about people's medication use. We have data about people's inpatient encounters if they're hospitalized. So using the traditional secondary data sources, and we relied on these data for our primary outcomes. So rather than relying on people telling us anything, we relied on these data that were already being collected. And so unless people explicitly said they didn't want their data to continue to be used, even if they withdrew from the study and said, I don't want to do any more surveys, I don't want to get your mailers anymore, we were able to keep their data in the study. And so ultimately what this resulted in is of the 2380 in the education arm who were randomized, we were able to analyze 2374 of them for the primary outcome. While that number obviously dropped off significantly for the patient-reported outcomes, our study was still adequately powered with respect to the primary outcome. And maybe one of the last challenges I want to talk about with a study like this is it ethical? Is it ethical to give people a benefit and then take it away? So some of you have seen this before, I'm sure, but every Halloween, Jimmy Kimmel had a tradition of challenging his viewers to prank their kids by telling them that the parents had eaten all of their Halloween candy. And you can imagine the kind of responses that are recorded from these children. And some people, from ethics boards to editors to peer reviewers, have raised the issue that what we did in the Access trial was something similar to this, that you gave people something for a time-limited period and then yanked it away from them when the trial was over, and that there may be some ethical quandaries with this. And this really stems from concerns around the fact that with more disposable income, some people may have upgraded their homes or vehicles or otherwise committed those funds, not fully anticipating that the benefits, or not fully appreciating that the benefit was always designed to be time limited. This is an interesting question and has a lot of relevance for many different interventional studies, especially policy trials that we all do. Is it ethical to give people something even if we can't promise it forever? And so we were quite interested in this, and we decided to do a study to actually ask participants about this and see what they thought about this after they completed their intervention. And we published on this fairly recently. If you're interested, it's in Trials, just came out a few weeks ago. And really what you can see from the quotes here is that the participants in our study were really quite thrilled with the study, even if they had to go back to paying for their medications at the end of it. In no way did that detract from their overall impression of being participants in their study or in their interest in participating in future research studies of this nature. So these are some of the reflections that we've had from the Access and the FoodRx trials to date. And I'm going to pass it over to Terry to go through some kind of lessons that we've learned along the way at a broader level.
Yeah, so from all these conducting these policy trials, we've faced many challenges, as Dr. Campbell has shown, but we've learned many lessons. So one of those is the importance of relationships with government and policymakers. One of our successes with Access was forming those strong partnerships with Alberta Blue Cross, Alberta Health Services, and Alberta Health from the very beginning. So having those stakeholders engaged at the beginning, they were invested and they were very engaged in the project. Sometimes it is challenging to manage the multiple expectations from the stakeholders, but it is necessary in a policy trial to have those relationships. The second lesson learned is that recruitment is hard, as you've seen. It was much tougher for us than we ever did anticipate, and it took a lot of trial and error to find the appropriate methods. What we did learn, though, is active methods of recruitment worked best. So really engaging with the recruitment partners, as in with Access, we engaged with pharmacies, and we ensured that we had a continuous communication between the research team and the pharmacist, and that really helped to engage and to push our recruitment efforts. And targeted recruitment is also very successful. So tailoring your recruitment method to the specific participants that you're trying to recruit. So for example, with our FoodRx project, we were getting participants that were struggling with food insecurity. So we partnered with the Calgary and Edmonton food banks, and they were active in recruiting for us and put flyers in every hamper they gave out. And that was very successful for us to have targeting the correct population. The third lesson is that health policy trials are complex for multiple reasons. So Dr. Campbell did touch on the FoodRx program and providing an intervention such as healthy foods seemed simple enough, but wasn't quite as straightforward as we thought. Large companies didn't have the systems in place to implement the interventions, and there were a lot of constraints and complexities that are involved. But so it's important to have like a lot of communication with the team that you're working with, and to plan ahead and to have a contingency plan in place. Also, the political environment really affects a policy trial, as shifting priorities and policies of the current government can significantly impact your trial, the timelines, the funding, and the operation. So planning ahead and making a risk management plan is essential. And then ethics and consent processes also make policy trials complex. There's a fine balance between simplicity and pragmatic design and the legal and ethical requirements. So real world setting pragmatic projects often require waivers of consent that can be difficult to navigate, and it requires a lot of ethical oversight. And the approvals can take a long time. So you need to engage early with ethics and to overcome the barriers and avoid delays with your projects. And this slide shows some of our current and ongoing projects that the Health Policy Trials Unit is involved with. I won't go over all of them right now, but I'll just touch on a few. So we are doing an expansion of the MOXIE trial. So this is an adaptation of the educational platform that was in the Access project that Dr. Campbell just mentioned. So this project is a randomized control policy trial that tests the effectiveness of MOXIE, which is a novel self-management education and support system that was designed in collaboration with a creative marketing agency. We're testing the impact of the intervention now in a wider range of population, in an unselected population of patients with cardiovascular related chronic conditions. And we hope to have that up and running in 2025. And we will be looking at the rates of rehospitalization in this population. The second project I'd like to mention is the NUDGEX trial. So this is a randomized control trial that will send flu vaccination messages in the form of letters that will be sent directly to participants, and will either be a generic flu messaging or stroke prevention messaging in the fall of 2025. to determine the most effective messaging for increasing influenza vaccination uptake in Alberta. And the third is the BC Farmers Market Nutrition Coupon Study. This project is being conducted in collaboration with the BC Farmers Market and the BC Ministry of Health. And it provides coupons to low-income families that can be redeemed for fruits, vegetables, meats, dairy, and other healthy foods within the BC Farmers Markets for a 16-week period. This policy trial will test the impact of the different amounts of coupons to see if there's a minimal threshold that will help with food insecurity. So where is the Health Policy Trials Unit going? What's our next steps? We are focusing on strategic growth and business development at this time. We want to expand our awareness of the HPTU, both internally and externally to the university, and to build capacity within our unit. We are also launching a networking event in spring 2025 that will bring the policymakers and community organizations together. And we want to develop a cost recovery method for the Health Policy Trials Unit to support other researchers that are in this environment. So some training for research staff in the policy trial space. And we're working on partnerships with other institutions as well. And then fund development, we are currently funded by ACT and are looking to obtain funding to make our unit sustainable in the long term. And although we have a focus on a lot of trials that are in the healthcare system space, we want to expand into other organizations in our community. By launching this event in the spring, we'll bring community partners together with policy researchers, and this will give us some opportunity for collaboration, and that we can discuss the barriers and challenges of implementing policy trial projects with the community partners, and they can understand the types of work that we do. And then we're also, we are a new unit just in the last few years because of ACT Canada, and now we're looking for a right home within the university and to sustain us long term. So what support can the Health Policy Trials Unit offer you? We are doing trial design. We can work with the organization to understand the gaps in current policies or provide evidence-based recommendations for improvement with policies in your organization. We can guide trial operations and operational advice by giving support from our research staff, or guide trial design and execution with community partners. And we can also train staff in policy trials, implementation, and planning. We also do some analytics and knowledge mobilization, and we can deliver data-driven insights for decision-making and assist in monitoring and evaluating trials. And we can help strengthen relationships with government organizations and community partners, and facilitate collaborations with key stakeholders and partner engagement. So if you do have any collaborations you'd like, or that you'd like to learn more about the Health Policy Trials Unit, please visit our website at the QR code here, or contact us at hptu@ucalgary.ca. Thanks, everyone.
Thank you very much for this exciting presentation about the policy trials. And let's see, there's several questions in the Q&A first. So here's a question. It says, really exciting work. In terms of investigating the why a health policy intervention works or doesn't, what is your methodologic approach to this? What data and outcomes do you collect? Do you incorporate behavioral science models and approaches?
Yeah, I can take that one. I think that's a really good question. I think you're absolutely right. I think a lot of times clinical trials are not meant to answer the why question. They kind of tell us if something works, and and it kind of ends there. I think one of the advantages of doing a really pragmatic trial is that we can build a number of pieces around it in terms of studies within a trial that are more explanatory, either quantitatively by collecting patient-reported outcome measures, behavioral metrics, et cetera, or even qualitatively. I think all of our studies, we build in qualitative studies around them so that we can understand more of if this works, why, and if it doesn't work, why not? And that's always been key to all of the trials that we've done. All of our trials have been informed by behavioral science theories, and we do incorporate those methodologies within the trial methodology to make sure we're capturing the right outcomes depending on the study. So we don't have a fixed model or framework that we use. It really depends from each study on its own objectives and merits, but certainly those are things that we try to incorporate in all of our studies, and always have behavioral scientists on our studies as we do them.
Yeah. But I had a question when you were talking about your first example. When you're randomizing individuals to a particular type of policy. And the way I think of policies that would apply to an entire group of people or to a region or a community or so. So have you considered doing clustered randomized trials? So you now would take a particular type of policy that you want to assess whether it would work or not, but now look at it by randomizing entire communities or groups of people to the interventions.
Yeah, absolutely. I think that's commonly done in policy trials. I think for the ones that our unit has done so far, there have not been distinct enough clusters that merit that type of methodology, but it's something that we're always considering in terms of how we roll these out. There are some of the trials that we've been involved with that have used more clustered designs or stepped wedge type designs where people all get the intervention but at different times, and that allows us to analyze it that way. So we supported a trial of a community health navigator program, and that's the methodology that we used in that setting, is that different primary care networks offered the intervention to their patients in sequence with each other. So there were those types of approaches. So we've done that, but other people have as well. Amity, I don't know if you want to comment on that further in terms of clustered designs.
I don't have any other examples to add, but I would agree that I think that's a great design option to use for this kind of study, and that's more commonly used in pragmatic designs in general. And yeah, I think it's definitely one of the models that I've not being a trialist, but originally I'm a newcomer to trials. I've spent quite a long time focusing on reading and cluster designs. So I'm looking forward to the opportunity to try that out.
I also had a second question, if you don't mind, and that is, every trial, whether it's a clinical, very clinical trial and looking at particular medications or devices or behavioral changes, the idea is that we may show that something is efficacious and it works, but then we're also held to, is this going to work, as you say, in real life? In real life, some of these things you can make into policies, but not everything can be made into policy, right? So if you say the policy is that we should eat healthier or exercise more, you cannot have a policy that works for that. But some countries, for example, I know the experience of Chile, they decided to have a policy of labeling every food item with whether it was green, yellow, black on, so they didn't, I guess they bypassed red and went to black on sugars, fats, calories, salt, I think 6 or 7 different items. And they just did that as a policy. They didn't test it. They didn't do a randomized controlled trial on something like this. And so now they had, I guess they're now wanting to do an implementation test or effectiveness of the implementation. So where do policy trials fall in relation to implementation trials? And should every trial eventually have some sort of policy component to that trial if you want it to be implemented.
Great question. Amy, do you want to take that?
There's a lot. It's very interesting to think about. I guess a few thoughts. I mean, I think more and more trials have added in like doing health economics analysis. I think that's an important component of understanding implementation, and also adding in other kinds of implementation studies. I think all of that is a really strong idea in order to actually be able to put whatever you're testing into place. But it also seems like a lot to add into a clinical trial testing a drug, for example. So I think maybe we should think about that continuum a little bit more, and like at what points and at what points adding in those other elements would be the most useful, and who can do those support those elements.
But I think the other thing that we often struggle with, Shrikant, is that the same idea is that sometimes a decision maker will say, well, we did this, so can you tell us if it worked? And those of us obviously in the trial space know that if we don't have control data, we can't really say if something worked. I mean, you can sometimes do pre-post assessments, but we know that the level of evidence is just not nearly as strong as if it was a prospectively designed trial with a proper randomization and control group. There's just so much confounding that happens in the kind of natural selection of these things. And so we offer, through, as Amity said, we are embedded within the Center for Health Policy at our institution. So sometimes what we say is that if people are interested in doing these retrospective policy analyses to say, what was the impact of this implementation? Could we have done it better? What were the implementation barriers? We have other people in our institution who do those types of studies, but we try to say, as the policy trials unit, we're really interested in earlier stage interventions when people haven't launched them yet but are planning to, and come to us and say, how can we make sure this is effective? And then we can actually design inform an appropriate design where we'll actually generate the highest quality evidence. So I think any evidence is better than none, but we all know that kind of prospectively designed randomized evidence is going to be the best we can get.
And so what is the role of, I mean, you did the qualitative analysis of some of these studies. So
yeah,
I mean, in every policy, it's the acceptability of the policy and these sorts of issues that I think it's one of the things that we don't incorporate very well in your standard clinical trials, but integrating it with qualitative analysis, I think, is the way to go.
Yeah, it's super helpful. It's been super helpful for us to understand, a lot about the intervention. And, Terry mentioned the MOXIE part, right? I think it was a bit of a surprising finding to us that using that advertising-based education module, we were able to drastically reduce the hospitalizations. That wasn't something we necessarily anticipated. And so our qualitative work around that really helped us understand what the factors were and how that may have worked. And so that's informed future work in that space to basically say, yeah, this wasn't just a spurious finding, but there were behaviorally motivated things that changed because of this. So yeah, I think doing some more of that exploratory, explanatory work alongside the trial is really important. And that's something we always try to incorporate or encourage investigators to do.
There's one other question. I mean, you guys were talking about lessons learned, and that was very good. So there's a question here. Are there any evidence databases or clearinghouses that collect these lessons learned or best practices to help trialists with designing policy trials?
I think that is Terry Saunders-Smith.
Yeah, I think policy trials are pretty rare. Like, they're not commonly done. So yeah, I think
maybe you should start one.
Yeah, it's a
great idea. I don't know of one, but I think that's a great idea to start one.
Interventions are, of course, dependent on the political landscape and public views on the policy. Do you measure this in any way?
Very good question. I think, go ahead, Amy. Yeah, go ahead.
Oh, I was just gonna say, well, we've I guess we've measured it in a way where we've personally experienced it, but in terms of how it's impacted our studies, I don't think we've measured it, but I have in a different project that is also part of the Center for Health Policy, it's an implementation study of a policy at this higher level. So one of the components of that we've included is like doing interviews with the people, like with the policymakers and the people designing the policy to like get at what is going on in that political landscape thing. So I'd say it's another place where qualitative work can help, but there are some policy level like implementation science measures that I've been trying to figure out how we can start to use. So if we figure out where this clearinghouse is, then those are some links we could share on that website.
Yeah, I was just going to add that I think Amity made the point earlier that evidence is only one thing that informs policy. I think some of these other things, the political will, the public's opinion, these are all things that also contribute to whether a policy is truly enacted or passed as policy or legislation. I see my role as a scientist and as a trialist, not necessarily to comment on those things, but more to provide the evidence that can be kind of fodder for some of those discussions. So to me, that's kind of part of the knowledge mobilization that happens as part of a policy trial, but the policy trial itself is somewhat divorced from those, trying to take a more scientific, objective approach to it to say, does this work? A secondary question is this acceptable? Now that we know it works, are people interested even with that evidence? But I think a lot of times the public and even policymakers are making opinions on a proposed policy without evidence. And I think that's where policy trials can really come into play, is providing that evidence and informing more rational discussion.
Wonderful.
Okay, on to you, Ipsita.
Well, thank you so much to all of our speakers for joining us today, and for the Health Policy Trials Unit for sharing their studies with us and those important lessons learned. Lots of considerations there for all of our trialists to be thinking about. And now they also have a resource to reach out to as they start to think about some of their broader scale policy related trials that they might be interested in pursuing. So thank you so much for sharing. And finally, I'd just like to invite you to our next webinar in January, which will be with one of our patient partners and a partner from the University of Ottawa. They're going to be doing a talk called Engaging Patient Partners in Your CIHR Grant Application, Everything You Ever Wanted to Know. So it'll be all about how to engage patient partners effectively and working through challenges, barriers, etc. So I hope you can join us for that. Thank you so much for joining us for all of our webinars